And now we're going to talk about the main causes of fractures and talk about the processes involved in fracture healing. Again, at only a very simple overview level. So we know that women are more likely to be admitted for fractures, and that's often in the elderly. In particular, it's related to osteoporosis. And if we're looking at this image, we're just looking at the bone mineral density, so the total mass of skeletal calcium in grams against age. And what you can see in both males and females is that the peak bone mineral density is at around about 30. It stays relatively stable for a few years, and then it starts to gradually reduce. And it's more significant that bone mineral density is lower to start with in females, but it also has a more significant drop down to the menopause and the loss of estrogen. And of course, in males, you're getting a gradual reduction in testosterone levels, so that also reduces. So women, therefore, are more susceptible to osteoporosis than men, but it doesn't mean that men don't get osteoporosis, because they do. So what are some of the risk factors, if you like? Well, there's a low bone mineral density. So if you have a lower bone mineral density than you should have, that means you've got less mineralization, and therefore you're likely to have weaker bones. You might have immobility. And if you're immobile, it means there's less weight bearing, and therefore the bones become weaker, because the more weight bearing exercise, you actually strengthen those bones and increase that bone mineral density. You may be in those low estrogen states, so for example, during menopause. And of course, estrogen is bone protective because it helps to stimulate the osteoblasts to lay down bone. And if estrogen is bone protective and you don't have as much bone, then of course, have as much estrogen, then of course that reduces. There are a variety of endocrine disorders that can lead to fracture risk. For example, Cushing's syndrome. This is where you have an excess of cortisol. It can be down to corticosteroids as well. But that leads to increased osteoclastic activity and reduced osteoblastic activity. So you get more proteolysis of bone structure, leading to likely osteoporosis or osteopenia, and increased fracture risk. Other things that can cause it, of course, things such as hyperthyroidism and hypogonadism. And just for information, some antipsychotics can also increase osteoclastic activity, therefore reducing your bone mineral density and your bone mass. A previous fracture generally means that you're more likely to get another, but especially if it hasn't fully healed or it hasn't healed appropriately. And we talked about drugs such as corticosteroids, which is your cortisol in essence, and we talked about some other antipsychotics as well, stimulating bone breakdown. Other things that might do it, so some bone cancers, of course. Bone cancers may be more likely to lead to fractures because they're basically weakening the bone because they're being taken over by that cancer. So some of the structure might start to disappear. So what about in younger males? Well, it's more likely to be musculoskeletal trauma due to things like transport, sport, or occupation-related incidents, so repetitive force. And in young children, they're more prone to fractures than sprains and strains because their growth plates are weaker than their ligaments, muscles, and tendons. So what about some of the clinical manifestations? So these may be related to the location, the severity, and any comorbidities that may be present. But generally, people will get pain, they'll get swelling, and they may get a loss of function as well. So you really need to be thinking about the following. And remember, when I'm giving you this information, this is coming from a non-clinical person, so you need to bear in mind what the clinicians or how clinicians would train you moving into the future. So pain, so you would be thinking about things like pain. So pain may not immediately be evident because there might be nerve damage at the fracture site, for example, and sensation may be lost if there is that nerve damage. So a numbness can sometimes last up to 20 minutes due to potential nerve damage. You then may have deformities. Do you have fracture displacement? Is the swelling evident? What about the colour? There may be pallor may be evident if the blood supply has been cut off, for example. So if it's pink, it indicates that the blood supply may be okay. Whiteness indicates it may not be quite so good. And then related to that, you've got warmth. So if it's warm, then it suggests that there's still some blood supply getting to it. But if the blood supply is cut off, it may be cold. There may be blood loss. Or even it might be cold because someone's applied ice and it feels cold. And movement. Do they have full movement that is desirable? Is there any movement at all? Is there an inability to use limbs? So these are some of the things as a clinician you'll be thinking about. But like I said, talk to the musculoskeletal specialist to get the best information. So what are some of the fracture complications? So wound infections are a frequent complication of an open fracture, as you might expect. So, for example, you may get osteomyelitis, so that's infection in the bone. You may get blood vessel damage, because the blood vessels might be lacerated by bone fragments. That can lead to hemorrhage, of course, so you get reduced blood delivery to the tissues. You might get large amounts of blood loss and associated hypovolemic shock. Tissues might become cold, as we've talked about, due to that lack of blood supply. You may lead to some thrombosis in limb injuries, such as DVT. Thrombus, of course, can lead to an embolus, for example, in pulmonary embolism. So there are lots of things to be thinking about with those further fracture complications. We talked about a little bit about nerve damage. They can be compressed, leading to chronic pain or paralysis, depending on what has happened in terms of that nerve damage. So you can get chronic pain, you can get complete paralysis, and of course, surgical intervention may be needed for pain control or for function to return. You may get delayed bone healing or union or malunion. So delayed union, of course, can lead to misalignment of bone ends, for example, caused by improper splinting, as an example of that. And of course, you may get non-union. So this is unsuccessful union of the bone ends themselves. So what are some of the goals of treatment? Well, of course, you want to realign any bones, you want to immobilize in the initial phases, and you want to restore. So you may be giving pain relief. You may be giving splints to stop movement of a broken limb, braces to support the bone, maybe plaster casts to provide support and immobilize the bone. And of course, finally, you may have surgical insertions of metal rods or plates, helping to hold the various pieces of bone together. So now we're just going to go through a basic overview of bone turnover and bone healing. Now the first bit is very simple. It's really talking about some of the types of bone cell. So there are the three main types that we always kind of talk about. So you've got your osteoclasts, which are promoting the resorption of bone. So they release proteolytic enzymes, they release acid, they release alkaline phosphatases, which can help to break down the mineralized bone and release the calcium and phosphate, and therefore allow the osteoblasts to get working to synthesize and secrete collagen and promote deposition of calcium phosphate crystals. Now, so you've got the bones that break down, so that's the osteoclasts. You've got the bones, the cells that make, that's the osteoblasts. And once surrounded by calcified matrix, the osteoblasts become osteocytes, and they're involved in the detection of bone strain, and they help to signal to the osteoblast and osteoclast what needs to be done. And they have that essential role in the exchange of calcium between the ECS and the bone and that stimulatory processes. So fracture healing helps to restore the tissue to as near as possible to its original physical and mechanical properties. And it's broadly broken into three main stages. So you've got phase 1, which is the inflammation stage, and that can last around about 7 days. You've then got the repair phase, which is broken into two parts. You've got the soft callus that initially forms, followed by the hard callus. That can take a lot longer, can take up to that 40-day period. And then you've got the final phase, which is the full remodelling, and that can take well over 100 days in some cases. And what we're going to do now is we're just going to go at a very simple level through each of these phases. We're going to talk about, at a crude level, inflammation, repair, and remodelling. So first of all, we're thinking about the inflammatory stage, and that begins with the formation of a haematoma, which is obviously a localized collection of clotted blood outside blood vessels, and that can be due to trauma, for example. And at this point, the bone cells, such as your osteocytes, are dying at the initial stage with that haematoma formation. You're getting those torn blood vessels and that hemorrhage forming. And that clotted blood forms at that fracture site, as we've already said. The site then becomes swollen, painful, and inflamed. So that's your inflammation, and your macrophages are there, and they're helping to clean up the dead tissue. And the dead tissue itself stimulates a huge inflammatory response because it's releasing the various chemical messengers, so your histamines and your prostaglandins, for example. The chemical release also helps to decalcify the ends of the fractured bones through the stimulation of various cell types, and the phagocytes are there to help clean up the dead tissue. And that dead tissue might be dead red blood cells, and it might be your osteocytes. And at this point, the release of all these chemical messengers helps to stimulate the osteoblasts and the osteoclasts to become attracted to the area and begin to proliferate. So the next phase is when we start to form the soft callus, or the fibrocartilaginous callus. God, I'm not very good at saying that, am I? So this is where we're getting the deposition of collagen and fibrocartilage, and it forming a soft callus a few days after the initial fracture. And really what's happening is fibroblasts are laying down collagen, and your osteoblasts are laying down the osteoid, the cartilage. But we're also getting new capillaries forming due to the release of a variety of growth factors, of blood vessel growth factors. And so we're now starting to get an increased blood flow into the wound as the capillaries are growing in, and we're forming this soft callus, and the inflammatory response is reducing. And then we can move on to the next stage, and this is where we're getting ossification, causing the formation of a hard callus. And so at this point, the fibrocartilaginous callus converts to a bony, hard callus, and we're starting to get some calcium deposition and the formation of spongy bone. The bone callus begins around about 3 or 4 weeks after your injury and continues until there's firm union. And that, again, on average is going to take 2 or 3 months, but of course may be longer. And finally, we move on to the bone remodelling, and this is the final process. This may occur for up to a year in some cases, and we're gradually getting a reduction in the bone callus, but this bone callus may never necessarily completely go away, but it does usually heal stronger than the surrounding bone. So the excess material on the bone shaft exterior, as you can see in this image, and within the medullary cavity, which is shown, is removed. So osteoclasts are helping to remove that material so it can go back to resembling its original structure. It also helps to remove any small bone fragments. And the compact bone is laid down to reconstruct the shaft walls. And this is being laid down by the osteoblasts as it continues to strengthen. So finally, I've just got a little question for you. It's nice and simple. And all I want you to do is look at these images and in relation to fracture healing, link the stage with the appropriate image and just state the correct order of events in the healing process. So don't go back and have a little look. I just want you to have a look at these 4 images. So here are your 4 images and which one of these goes to which image and which is the first stage, which is the second stage, which is the third stage, which is the fourth stage, and name those stages. Okay, off we go. Press pause, have a think, and then we'll go through it. So hopefully you will go through it now. So hopefully you said haematoma. Of course, is the first stage. We're getting a blood clot formation, and that is clearly linking to this image here. What's the second stage? Second stage, of course, is we're starting to form the soft callus, and we're getting the new blood vessels coming through to feed in the nutrients, etc. So that's your second stage. Third stage, of course, we now go from the soft callus into the hard callus, and this is your ossification, and again, you're seeing it forming in this point. And then finally, bone remodeling, of course, where we're forming that final compact bone, hopefully as good as new. All I'd like you to do at this point is just remember this is really a very basic overview, and it's a good place for you to start in your journey of understanding about bone structure, bone healing, and bone fractures.